multiple tracks for us today. So I'm sure this is going to be a very, very nice session. Please follow us on social media and subscribe to the YouTube channel. This series is there on the YouTube. It's being broadcast live now on YouTube, and it's going to be saved there as the previous sessions I sent to all of my colleagues and to the Heart Center team here, because I really found this last 3 sessions very interesting. Is going to be completed with this one today, and then the next 2 ones. This really a nice series that we are doing, and I'm very proud of that. And just remind you guys to save the date. In August and September 2023, we are going to have the World Congress of Pediatric Cardiology and Cardiac Surgery. It's going to be in the US. It's going to be in Washington, DC. This is going to be an awesome meeting, and Congenital Heart Academy is one of the educational partners of the World Congress. So a lot of things are going to be prepared for you guys this year and next year. I want to invite all of you to attend our journal club. The first one was really nice, and I'm sure this one is going to be nice as well. So in the honor of Dr. Gary Webb, Congenital Heart Academy and the CHIP network is promoting once a month one journal club. We are going to talk about a pulmonary valve replacement done by mini thoracotomy. So a minimal invasive surgery. We are going to debate not only for pulmonary valve replacement, but we want to discuss about minimal invasive cardiac surgery. We are going to have very nice panelists, a lot of surgeons that has experience on that. I'm sure everybody is going to learn a lot on this journal club. And if you have a suggestion, if you want to present a paper, please email me on congenitalheartacademy@gmail.com, and we are going to be happy to organize for you to present a nice paper in one of our journal clubs. And on the 27th of February, we are going to have our fetal cardiology series. It's going to be another interesting talks by Dr. Rima. She's the course organizer, and she's preparing the 3 nice talks for us. Outstanding speakers are going to be with us. So please join us. And I'm very, very happy to announce that our dear Professor Norman Silverman is coming back with his series. It's starting in February. He's going to do this once a month. So please save the dates and join us. The series is really nice, and I'm sure all of you are going to learn a lot. I always learn with him. And we have some meetings that we are promoting with other organizations. So I want to invite you to, on the next Saturday, to join the Cardiac Anesthesia, Congenital Cardiac Anesthesia Society. They're going to talk about heart failure, from the diagnosis to treatment of heart failure, and it's going to be very nice. Please join us. And we are going to have another very interesting meeting. We had last year the first, the Silva Center Epstein Anomaly Symposium last year. This year, we are going to have again outstanding speakers. The topics are very interesting. I'm sure everybody is going to learn, and Congenital Heart Academy is very proud to be a partner of them. And I want to invite you to take this ECMO course. This is basically for adult ECMO, but all of the concepts, they apply for pediatric ECMO as well. This is a very nice course that took us from also around 2 years to place together. I'm very proud to be on the editorial board of this course, and I wrote 2 chapters myself. And so we really want to invite all of you to take this course. We're going to learn a lot, and please recommend this course to your colleagues as well. Just a kind reminder, we always talk about this. This is a very nice hands-on training course about surgery on Congenital Heart Academy. Once a month, we have a different pathology, a different cardiac disease that is being taught by the Sick Kids team, and Sasha is one of the proctors as well. They say if you subscribe, if you register, they're going to send you a 3D model, very beautiful 3D model, and you're going to be able to do the surgery yourself with the proctors helping you and give you all the tips and tricks. This, if you're a surgeon, this certainly is very interesting. And now with you guys, Dr. Anderson and this amazing team to talk about the ventricular outflow tracts.
Well, good afternoon again to you, ladies and gentlemen. So this afternoon, we will complete our assessment of normal cardiac anatomy. And as you can see, we're going to finish with a discussion of the arterial valves. You will remember that last week we discussed the atrioventricular valves, and we described them in terms of a complex. And the complex for the atrioventricular valves was the combination of the leaflets with the tension apparatus. So today, we're going to look at the arterial valves in terms of a complex, but this time, what we're going to emphasize is the interrelationships between the leaflets, the moving parts of the valves, and the supporting valvar sinuses. And what we're going to emphasize is the difference between the arterial valves in the morphologically right ventricle, usually the pulmonary valve in the normal heart for sure, and the valve in the left ventricle, the aortic valve. And that major difference is that the right ventricular outlet is a completely muscular infundibulate sleeve, whereas, as I'm sure you all know already, the essence of the aortic root is the presence in the roof of the left ventricle, fibrous continuity between the leaflets of the aortic valve, the arterial valve, and the atrioventricular valve, the mitral valve. And we're going to look at that today. I'm going to be helped again by Diane Spicer, who's going to be presenting to you videos of dissected hearts. And then Justin Tretter from Cincinnati is going to show you virtual dissections. But let's start off with a few words again on the developmental background, because that sets the scene for what we are about to discuss. And you will all know that to understand the development now, we've been using these exquisite reconstructed data sets that have been prepared by Wout Lammers and Jill Hickspoors from the University of Maastricht in the Netherlands. So here you're looking at an en face view of the developing right ventricle in a human embryo at Carnegie stage. You'll remember CS stands for Carnegie stage 20, and the embryo, as you see, is 7 weeks after conception. And what you can see there is the developing pulmonary root. And to the right of the pulmonary root, to your left hand, as you look at the screen, you see the developing aortic root. And at this stage, both of the aortic roots, as I'm going to show you shortly, are still positioned above the cavity of the developing right ventricle. But within the right ventricle, as we've already discussed, the embryo is building a shelf so as to put the aortic root in continuity with the left ventricle. And the embryo is doing that by muscularizing the fused proximal cushions. So here I've just tilted the data set so that you can look at it from the front, and I've taken away the proximal cushions. And now you see both of the arterial roots, but you can barely distinguish between them because they are positioned one in front of the other. They are both above the cavity of the right ventricle. So what the embryo is doing is building this shelf in the roof of the right ventricle. And there it is. And the embryo is muscularizing these proximal cushions that are fused together. Now at this stage, Carnegie stage 20, there is still a communication between the right ventricle and the aortic root. And that communication is the tertiary interventricular communication. At the end of the embryonic period of development, which is Carnegie stage 21, that tertiary interventricular communication has closed. And now this is what the situation looks like when I show you the relationship between the aortic root and the developing left ventricle. Again, we're looking at it from the front. So there you can see the aortic root, and it is now connected to the left ventricle. But as you can also see, it is positioned in space above the cavity of the right ventricle. It is aligned with the right ventricle. And this shows a significant difference between alignments and connections. And we're going to discuss that in our next session when we get on to understanding sequential segmental analysis. But at this stage, we want to look at the aortic root. And now the membranous septum has closed that tertiary interventricular communication. And in so doing, it has converted the secondary interventricular communication into the left ventricular outflow tract. So we can now rotate the data set so that we can see up into the subaortic outflow tract. And we can also see in this picture how the muscularization of the cushions has completed the subpulmonary infundibulum. And that is lifting away the developing pulmonary root from the base of the ventricular mass. And so the proximal portion of the outflow tract, together with those proximal muscularized cushions, has now formed the freestanding subpulmonary infundibular sleeve. So there is the aortic root in connection with the left ventricle, but there's also a significant point to note at this stage. There is the mitral valve, and when you now look up into the roof of the ventricle, there is still myocardium interposed between the developing leaflets of the aortic valve and the developing mitral valve. So at the end of the embryonic period, the aortic valve is still supported by a completely muscular infundibulum, but with ongoing development and with formation of the inferoseptal recess of the left ventricle, which we discussed last week in the context of the mitral valve, this subaortic infundibulum is converted into fibrous tissue. And that is what we are going to be looking at now, the difference between the arrangement in the right ventricle and the arrangement in the left ventricle. So this is what the definitive situation looks like. You're now looking down on the base of the ventricular mass, and there is the aorta. And those muscularized cushions have formed the subpulmonary infundibulum. There is the freestanding subpulmonary infundibulum, and they have separated themselves from the aortic root. And this means that in the normal heart, there is no muscular outlet septum. Those cushions have become the freestanding subpulmonary infundibulum. And in fact, I can cut away the entirety of the pulmonary root, and I can show you that freestanding infundibular sleeve. And Diane will very shortly show you this self-same situation in a dissected heart, and she'll show you the tissue plane that separates the freestanding subpulmonary infundibular sleeve from the aortic root. So in normal development, those muscularized proximal cushions become the subpulmonary infundibulum. And they insert to the ventricular septum between the limbs of the septomarginal trabeculation. And again, you're going to see that shown to you by Diane. But she's going to emphasize also to you the fundamental difference between what we see in the right ventricle and what we see in the left ventricle. So here you're looking at the left ventricular outflow tract, and there is the right coronary leaflet. And you'll note that the right coronary leaflet has muscular support. But when you look at the other leaflets of the aortic valve, there is the non-coronary leaflet, there is the left coronary leaflet, you see that they are in fibrous continuity. And they are in fibrous continuity with what we call the aortic leaflet of the mitral valve. Because that muscular roof of the right ventricle concomitant with formation of the inferoseptal recess, has transformed itself into the area of fibrous continuity between the leaflets of the aortic and mitral valves. And these are the features that now Diane is going to show you with dissected hearts, and then Justin is going to reinforce with virtual data sets.
Looking at the base of the heart, we see the normal relationship of the great arteries with the pulmonary trunk, anterior and leftward of the aortic root, which is forming the centerpiece of the heart and lies deeply wedged between the tricuspid and mitral valves. Here we see the right coronary artery and the left coronary artery arising from the aortic sinuses adjacent to the pulmonary trunk. If I pull the pulmonary trunk back, we can see the extent of the subpulmonary muscular infundibulum, or that muscular sleeve that lifts the pulmonary valve up off of the right ventricular mass. This coronary artery is the first septal perforator, and surgeons need to be aware of that when they're doing the Ross procedure. If we look at another heart where I have removed the pulmonary trunk, now you can see the complete circular nature of that subpulmonary muscular infundibulum. Here's the right coronary artery and the left coronary artery, again from the aortic sinuses adjacent to the pulmonary trunk. And if I pull it back, we can once again see that subpulmonary muscular sleeve that lifts the pulmonary trunk up off of the right ventricular mass. Opening the right ventricular outflow tract, you can see where I've removed the pulmonary trunk, and also appreciate the complete subpulmonary muscular infundibulum. This is the septomarginal trabeculation, and you can see that the cephalic arm rises up to become incorporated into that muscular sleeve. This is the caudal arm of the septomarginal trabeculation, giving rise to the medial papillary muscle. Here we're looking at the left ventricular outflow tract from posterior to anterior. So this is the left atrium, this is the anterior leaflet of the mitral valve, and the aortic valve. This is the left coronary orifice and the right coronary orifice. The support of the aortic valve within the left ventricular outflow tract differs from the pulmonary valvar support in that the aorta is partially supported by muscle and partially supported by the fibrous continuity between the anterior leaflet of the mitral valve and the aortic valve. It's typical for the right coronary aortic sinus to be entirely supported by muscle, with a portion of the left coronary aortic sinus to be supported by muscle, as well as a portion of it being supported by the fibrous continuity with the mitral valve. The non-adjacent or the non-coronary leaflet is typically supported in its entirety by the fibrous continuity between the mitral valve and the non-coronary aortic leaflet.
In these first sets of videos, we'll focus on the support of the pulmonary and aortic root. So we'll start with this adult data set. We're looking with the chest wall translucent, looking at the cardiac mass in the chest from a directly anterior position. And then we'll dissect into the heart, and we have the blood-filled cavities of the right and left heart filled with the right ventricle and the pulmonary root colored in purple. And we can see as we look at the anterior surface of the heart, which is primarily comprised of the right ventricular outflow tract leading up to the pulmonary root, that the pulmonary root is lifted up and away from the base of the heart by this freestanding infundibulum or muscular sleeve. And if we start to make the right ventricle and pulmonary root translucent, and I color the aortic root red, we can appreciate how that aortic root is wedged down in between the AV valves closer to the base of the heart. So very different position than that pulmonary root if we come back, which is lifted up and away from the base of the heart. And then as we rotate and make the rest of the heart translucent, and I've colored not only the virtual basal ring plane of the pulmonary root and the aortic root in green, but also the attachment lines of the tricuspid and the mitral valves in this pinkish purple. And you can better appreciate the aortic root being wedged in between the AV valves. And as we rotate leftward, we can see how the vertebral basal ring plane comes into contact with the annular attachment plane of the mitral valve in that area of fibrous continuity between the aortic valve and the aortic leaflet of the mitral valve. So this is the same adult patient. We're viewing up from the apices of both ventricles at the tricuspid and the mitral valve. And we have the same color coding of the attachment lines of the tricuspid and the mitral valve in this pinkish purple. Again, seeing that vertebral basal ring plane of the aortic root, which is in contact with the mitral valve. That's that area of aortic to mitral fibrous continuity spanning between the left and right fibrous triangle. And then we'll start to angle. So we're viewing up at the left ventricular outflow tract. We see that structure we've talked about, the infraseptal recess in its floor formed by that fibrous continuity between the AV valves. And we're looking right up at the aortomitral fibrous curtain going up into the non and the left coronary sinuses of the aortic root. And if we contrast that to the right ventricular outflow tract, we again see that the pulmonary root is lifted up and away from the base of the heart by this freestanding muscular sleeve or infundibulum, which creates fibrous discontinuity between the tricuspid and pulmonary valves. And then lastly, this is a 4D of a pediatric CT data set, a child with an incompetent aortic valve who underwent CT scan, and we've cut, we're standing anterior to the heart and we've cut, so we're looking at the anterior aspect of the aortic leaflet of the mitral valve, looking right up at that aortic mitral fibrous curtain between the aortic root and the aortic leaflet of the mitral valve. Again, spanning between the left coronary sinus and the non-coronary sinus.
So now you've seen the difference between the pulmonary root, the aortic root. So let's now cone down and let's look at the individual anatomy of each of these roots, and let's emphasize the differences between them. In both instances, the roots are going to extend from the vertebral basal ring to the sinutubular junction. And the feature of both of the roots will be that the leaflets are attached in semilunar fashion. And we're going to look at this first in the setting of the pulmonary valve. And what we're going to see is how those semilunar leaflets at the base interdigitate with the ventricular myocardium. And there is no ring-like annulus at the base of the leaflets, but there are rings to be found within the pulmonary root. The overall arrangement is that of a coronet. I'm going to show that to you very shortly. And the feature of the pulmonary root, as we've already discussed, is that the leaflets are exclusively supported by muscle. Now, Diane is going to show you a dissection like this again very shortly. Because what we have done here is to remove those leaflets so that you can see their semilunar hinges. And we're looking at the opened infundibulum of the right ventricle. And now you can see that there is a ring within the outflow tract. There it is. It is the union between the myocardium of the right ventricle and the fibrocollagenous walls of the valvar sinuses. But then, when we put in and take note of the semilunar hinges, we see that those semilunar hinges cross this anatomic ventriculo-arterial junction. Diane will be emphasizing this to you very shortly, but this puts myocardium at the base of each of the sinuses of the pulmonary trunk. But those semilunar hinges extend distally to the level of the sinutubular junction. And this produces what we call the interleaflet triangles. There are 3 such interleaflet triangles. You can't see the third in this dissection because I've cut through that interleaflet triangle so as to open the outflow tract. But I can now build up the pulmonary root on the basis of what I've shown you in this picture. So here is the bisected pulmonary root. And there now you see the junction between the myocardium and the sinuses, which is the anatomic ventricular arterial junction. There is then a second ring within the root, and this is the site of distal attachment of the semilunar hinges of the pulmonary valve. And this is the sinutubular junction. So now if we put in the semilunar hinge of those leaflets, you see how it crosses that anatomic ventricular arterial junction. So to repeat again, it is the fact that the semilunar hinge crosses that anatomic ventricular arterial junction that results in arterial wall being incorporated in ventricle to form the interleaflet triangles, and results in myocardium being positioned at the base of each of the sinuses. But then there is yet another ring on which we have to take account, and that is the virtual basal ring. Because this has no anatomic counterpart, this is formed by joining together the nadirs of attachment of those semilunar leaflets. But if we put the whole thing together, we produce this crown-like arrangement. And now we can see that the root extends from the sinutubular junction to the virtual basal ring. Remember, the basal ring is a virtual entity, and in the pulmonary root, the semilunar hinges cross the anatomic ventricular arterial junction. So now let's look at this feature in the context of the pulmonary root. We're going to look at it first again with real dissection shown to you by Diane, and then virtual dissections shown to you by Justin.
This is an open pulmonary valve with complete support by that subpulmonary muscular infundibulum. The pulmonary valvar complex extends from the virtual basal ring to the sinutubular junction, with the virtual basal ring at the proximal most component of the valvar complex, and it is a line that is drawn along the base of each of the semilunar hinge points, or at the ventricular aspect of the hinge points. The distal extent of the pulmonary valvar complex is where the semilunar valvar leaflets attach to the fibrocollagenous wall at the sinutubular junction. The interleaflet triangles are formed because of the semilunar nature of the hinge points of the valvar leaflets, and they lie between the sinus and the ventricle, so that there is some component of the arterial wall within the ventricle. If we look at the pulmonary valve with the leaflets removed, we can see that there is a complete ring formed at the ventricular arterial junction, and I've removed the leaflets so we can see the hinge points and the interleaflet triangles, and also that there is a crescent of muscle incorporated into each of the pulmonary valvar sinuses.
So looking back at our adult CT data set with the right ventricle and pulmonary trunk colored in purple, we can see the semilunar attachments of the pulmonary valvar leaflets and their sinuses from the outside. And so if we spin this around, we can see the semilunar attachments going from their zenith at the top of the interleaflet triangle down to the nadir of the sinus. And if we connect the dots at the nadir, that would form the virtual basal ring plane. And if we connect the dots at the zenith of attachment, that creates the sinutubular junction. So as we spin all the way around, we see the three sinuses, and inside will be the three leaflets. And now if we go in with virtual dissection, looking straight from anterior back at two of the sinuses with the leaflets still visible, and if we dissect in and I make the leaflets more translucent, then we can appreciate the semilunar attachment of the leaflet down to the nadir at the virtual basal ring plane, and then up to the zenith of attachment at the sinotubular junction. Between is one of the three interleaflet triangles. And then I've color coded so we can see how the ventricular myocardium is incorporated at the base of each of the pulmonary sinuses. And so now we're going to come up and we're going to dissect down into a short axis. There's the three leaflets of the pulmonary valve, and you can see that darker color ventricular myocardium incorporated into the base. And we'll rotate around so we can look at the base of each of the sinuses. So you can see that ventricular myocardium incorporated there. And then coming over to the side, we can see that ventricular myocardium as opposed to the arterial wall has this lighter pink color. So a truly annular attachment of that anatomical ventricular arterial junction.
So now you've seen the essence of an arterial route, and we've shown you the pulmonary route. We're now going to repeat this analysis, and we're going to look at the definitive features of the aortic route. But one of the things we have to remember about the aortic route is that it is the centerpiece of the ventricular base. In fact, when we look at it in frontal projection, it emerges from the heart in right-sided position relative to the pulmonary route, despite the fact that it's coming out of the left ventricle. And we can see that location of the aortic route very nicely when I show you this virtual dissection made by Shumpei Mori. Shumpei, as I've told you previously, was initially a cardiologist in Kobe. He's now working at the University of California in Los Angeles. And it was Shumpei who introduced us to all that could be achieved using virtual dissection. And you see very nicely here how Shumpei has shown you the relationship of the aortic route, and in particular, its sinuses. So there you're seeing the right aortic sinus, there, the left aortic sinus, and at the back, the non-adjacent aortic sinus, deeply wedged between tricuspid valvar orifice, which you're seeing to your left hand, the mitral valvar orifice that you're seeing to your right hand. And Diane is going to emphasize these features when she shows you a dissection of the short axis of the ventricular base viewed from the ventricular apex. And if you look carefully, you can also see that triangular area beneath the non-adjacent sinus, which we now know is the inferoseptal recess. But let's concentrate on the features of the aortic route. Because just like the pulmonary route, it is made up of leaflets and their supporting valvar sinuses. And just like the pulmonary route, the sinuses and the leaflets interpose one with the other to form the interleaflet triangles. Now, the aortic route has length as well as breadth, and as with the pulmonary route, it extends from the sinutubular junction to the virtual basal ring. So here now, I'm showing you a picture of the aortic route. This, in fact, as you will recognize, is simulated parasternal long axis cut as it can be obtained by echocardiographers. So to your right hand, you see the cavity of the left atrium. To your left hand, you see the cavity of the infundibulum of the right ventricle. And if you look carefully, you can appreciate the presence of that infundibular sleeve that has lifted the leaflets of the pulmonary valve away from the ventricular base. But we're now concentrating on the aortic route. And again, its feature is the semilunar hinges of the leaflets. And they are interdigitating with the valvar sinus and the supporting ventricular structures. Once more, the route extends from the sinutubular junction to the virtual basal ring. Now, we need to talk again a little bit on the words we use to describe the components of the route. So it extends from the sinutubular junction to the basal ring. We keep on saying this, but it is important to identify what we mean by the routes. But how do we describe its component parts? Well, you've heard these words used already again and again when we've been describing the pulmonary route. So the moving parts of the route we call the leaflets, and we distinguish between the leaflets and the sinuses, and you've already seen in the pulmonary route how the sinuses house those leaflets in semilunar fashion. We haven't emphasized yet, when discussing the pulmonary route, or at least I have not emphasized, the zones of apposition, which are the areas of union between the adjacent leaflets. But we're going to look at these in detail. Now we're looking at the aortic route. But you will also have appreciated that we have not used the word cusp. And that is because, to our mind, the word cusp is at the moment remarkably ambiguous, because many times it's used to describe the leaflets, but by interventionists, particularly electrophysiologists, they also use the cusp to describe the sinus. And we've emphasized the difference between the sinuses, the leaflets. And because of this, we recommend that it is best to avoid using cusp and instead all the time describe the interplay between the sinuses and the leaflets that they support. Now, we also need to look at the zones of apposition between the leaflets. So here now I'm showing you a view looking down on the closed aortic valve. And you see very nicely that the zones of apposition between the leaflets come together at the sinutubular junction. And these are the areas I'm sure that you all call the commissures. For me as an anatomist, however, a commissure is a union between two moving parts. So I would like to describe the aortic route as having three commissures extending to the center of the valve. We can't do that because you think of the peripheral attachments of the leaflets as representing the commissures. So now we're going to emphasize that these zones that extend to the middle of the valvar orifice or areas of coaptation, we're going to call these areas or zones of coaptation, but obviously they are an integral part of the competent valve. And these zones need to meet together snugly if the valve is to function in proper fashion. So now we're going to look at these features in the setting of the aortic route. We're also going to note additional key features. Again, we're going to concentrate on the ventricular arterial junction, and I would remind you that is the line of union between the ventricular myocardium and the fibrocollagenous walls of the sinuses. And then we're going to look again at the interleaflet triangles. And we are going to see now that there are subtle differences, but important differences between what we saw in the pulmonary route and what we see in the aortic route.
This is a short axis view from the apex that I thought was a very nice comparison to the image used by Professor Anderson and produced by Dr. Maury. So here is our right ventricle, right ventricular outflow tract, muscular interventricular septum, and left ventricle with our anterior leaflet of the mitral valve. Here is the aortic valve and the right coronary aortic valvar sinus completely supported by muscle. The left coronary aortic valvar sinus supported in part by muscle and fibrous continuity with the mitral valve. And the non-adjacent or the non-coronary sinus, which is entirely supported by fibrous tissue with that fibrous continuity between it and the mitral valve. If we look at the aortic valve from posterior to anterior, we can see the aortic valvar complex extends from that virtual basal plane to the sinutubular junction. The virtual basal plane is the most proximal component of the aortic valvar complex, and it is the line that is drawn at the base of each of the aortic valvar sinuses, or on the ventricular aspect of each of the sinuses. And this is used as an echocardiographic marker. The distal extent of the aortic valvar complex is at the sinutubular junction, or where the semilunar hinge points attach to the fibrocollagenous wall of the aorta. The aortic valvar sinuses are supporting the semilunar hinge point of the leaflets, and secondary to that semilunar hinging of the valvar leaflets, we have these interleaflet triangles, which are the fibrous parts of the wall between those semilunar hinges. The aortic ventricular arterial junction differs from that of the pulmonary ventricular arterial junction, which was a complete ring between the muscular infundibulum and the wall of the pulmonary trunk. Within the aorta, the ventricular arterial junction is both muscular and fibrous. If we look at a short axis view of the aortic valve, we can see the zones of apposition, or the coaptation point between each of the valvar leaflets. We can see the peripheral attachments of each of those zones of apposition at the sinutubular junction. And you can see this thickening within the aortic root where those peripheral zones of apposition are attached.
To discuss aortic root, we'll go back to our young child with aortic incompetence. So this is an endocast image with the blood-filled cavities filled. I've colored the aortic root and proximal ascending aorta in a darker red, and we can see the most anterior aspect of the heart includes the right ventricular outflow tract, and the pulmonary root. Again, the pulmonary root lifted up and away from the base of the heart by this freestanding muscular sleeve or infundibulum. And as we start to make the rest of the heart translucent, except for the aortic root and proximal ascending aorta, you can see how it is more deeply wedged between the AV valves sitting on the base of the heart. And at the anterior aspect, we're primarily looking at the right coronary sinus. We can also see a portion of the left and the non-coronary sinus. We'll take away the rest of the heart, and then we'll look at the three features of the aortic root, namely the sinuses, the interleaflet triangles, and once we go into the inside of the heart, you'll see the leaflets. The leaflets, again, are attached in a semilunar fashion like the pulmonary root, extending from their nadir, which together would form the virtual basal ring plane between the three, and then attaching all the way up to their zenith of attachment at the commissures, the lateral attachments of the leaflets, at the plane of the sinutubular junction. So in this patient with aortic incompetence, they have asymmetric dilation of this non-coronary sinus that you'll see better as we rotate around. But as we rotate, you can see the three sinuses and the three interleaflet triangles with the features that we've discussed. And here's that asymmetrically dilated non-coronary sinus in this patient. And so next I've created this 2D CT appearing image, except instead of looking from the foot up at this 2D plane, we're looking in a surgeon's view down at the plane of the virtual basal ring. So this is to the right of the patient, this is to the left of the patient, anterior and posterior. The virtual basal ring plane of the aortic root demonstrates the support of the aortic root, which is partly muscular and partly fibrous tissue. The fibrous tissue includes the membranous septum. It includes the aortomitrofibrous curtain, which spans between the right fibrous trigone to the left fibrous trigone, along with that structure that we talked about the other session, the infraseptal recess. So here we see the atrial septum and its muscular buttress undermined by the floor of the infraseptal recess, which is formed by the fibrous continuity between the AV valves. So the membranous septum, the floor of the infraseptal recess, the right fibrous trigone together forming the central fibrous body, the aortomitrofibrous curtain spanning between the right and the left fibrous trigone. That's the fibrous support of the normal aortic root. Then looking at the muscular support, we have the LV free wall and the interventricular septum. So we'll put the aortic root on top of this image. So we see that asymmetrically dilated non-coronary sinus, which is positioned back near the atrial septum, which is a common landmark to help us identify the non-coronary sinus by two-dimensional imaging. And then here is the right and the left coronary sinuses with their coronary arteries visualized. And now we'll go into a virtual dissection of the virtual basal ring plane. So you see those same structures, and we'll start to look at these different structures of support from different angles. So again, this is the free wall of the left ventricle and the interventricular septum. And we'll start to dissect into the free wall of the left ventricle so you can see the muscular support that is supporting that aspect of the aortic root. And then if we position anteriorly so we can see the interventricular septum, and then this is where we start to get into the fibrous support, being the membranous septum, the floor of the infraseptal recess, the right fibrous trigoon, the aortomitral fibrous curtain, and the left fibrous trigoon. And so we'll go into a 3-chamber plane. And just like we saw at the beginning, if we come back here and look at that aortic root, you can see that the entirety of the non and a part of the left coronary sinus is supported by that fibrous tissue, where a part of the left and the entirety of the right is supported by muscular tissue. So we'll come back to that 3-chamber view as we start to look in long axis of the anterior support, which is muscular, supporting that right coronary sinus, and then the more posterior support under this non-coronary sinus, which is formed by that aortomitral fibrous curtain. So here we see the aortic leaflet of the mitral valve, which is in fibrous continuity with the non-coronary sinus in this plane. And then we'll dissect it into a similar plane we looked at before in that 4D image, where we're looking at the anterior aspect of the aortic leaflet of the mitral valve, spanned the aortomitral fibrous curtain, spanned by the left to right fibrous trigoon in fibrous continuity with a part of the left and the entirety of the non-coronary sinus. And then we'll finish this by looking more into a short axis up from the apex, up at the left ventricular outflow tract. You can see that incompetent aortic valve and diastole. But again, you can appreciate from the underside the fibrous support by the aortomitral fibrous curtain, the infraseptal recess, the membranous septum, and then the muscular support under the right being the interventricular septum to the free wall of the left ventricle, supporting a portion of the left. And then here is looking back from superiorly down at the aortic valve in a 4D. You can appreciate the trileaflet opening and closure of this semilunar valve. And you can also appreciate the commissures, that lateral attachment of both of the leaflets, the zones of apposition that extend to the center. This patient, again, has aortic incompetency. We can see that failure of coaptation centrally, primarily related to the non-coronary leaflet. And then here is a 3-chamber long axis 4D image, just again showing the difference between the muscular support anteriorly and the fibrous support posteriorly under the non-coronary sinus.
So now you've seen the essence of the aortic root, and I'm posing the question, is there myocardium at the bases of the aortic valvar sinuses? And in fact, you know already that the answer to this is yes, but the myocardium is seen only at the bases of those sinuses that give rise to the coronary arteries. And we can see this very nicely in another of the virtual dissections made by Shumpei. Here you're looking at the aortic root from behind, so that you're seeing the left atrial appendage now to your left hand. There is the body of the left ventricle. You're now seeing the infundibulum, right ventricle to your right hand. So there is the level of the sinutubular junction. And if now you join together the nadirs of the semilunar hinges, you get the virtual basal ring. And what Shumpei has done to make this presentation is he's colored in purpley brown the myocardium of the left ventricular outflow tract. And that is demonstrating to you the level of the ventricular arterial junction. So we can find a ventricular arterial junction in the 2 sinuses of the aortic root that give rise to the coronary arteries. And in another of Shumpei's pictures, he's now looking down to replicate the picture I showed you a moment ago. You can now see the peripheral attachments that we call the commissures. You can see very nicely how those zones or areas of coaptation come together to give us a competent aortic valve. But if we look at the base right aortic sinus and the base left aortic sinus, we see myocardium in both of the sinuses. But you see, the myocardium is only present in half of the left aortic sinus, and then for the remainder of that sinus and the non-adjacent aortic sinus, there is no myocardium, because this is the area of fibrous continuity between the leaflets of the aortic and mitral valves.
Here again, we're looking at the aortic root and the left ventricular outflow tract from posterior to anterior. In this specimen, I have removed each of the leaflets of the aortic valve, so now we can see the semilunar hinge points as they are supported by each of the sinuses. The leaflets of the coronary aortic sinuses cross the anatomic ventriculo-arterial junction, and there is muscle incorporated into the base of these sinuses. This is the right coronary aortic sinus, and here we see that crescent of muscle incorporated into the base of the sinus. The left coronary leaflet or sinus has been bisected in this case, and we can see that in part it has a crescent of muscle at the base of the sinus. The opposite half of that sinus and leaflet are in fibrous continuity with the mitral valve, or the anterior leaflet of the mitral valve. The non-adjacent or non-coronary sinus is typically supported by fibrous continuity between it and the mitral valve. There is the right fibrous trigone and the membranous septum, which lies beneath the interleaflet triangle between the right coronary and non-coronary aortic sinuses, and those two areas, the right fibrous trigone and the membranous septum, form the central fibrous body. I would also like to point out that there is a very thin tissue plane between the transverse sinus and each of the interleaflet triangles. So here is the transverse sinus, and if I place my probe against the interleaflet triangle, you can see just how thin that tissue plane is between it and the outside of the aorta.
So this is our same young patient. Now we're cut into a plane where we're standing posteriorly looking into the left atrium. Here's the hinge line of the mitral valve. This is the aortic leaflet of the mitral valve and its hinge line. Here's its more lateral commissure with the mural leaflet coming around. Here's the inframedial commissure between the two leaflets. And this tissue right here is getting into the anterior aspect of the muscular buttress in the area that's undermined by the floor of the infraseptal recess. So if you pay attention to this location and right above, you'll see that we'll start to dissect into the non-coronary sinus. So there's the non-coronary sinus. We'll start to dissect into the infraseptal recess, and that tissue that sinus is completely supported by the fibrous tissue of the aortomitral fibrous curtain. Again, like before, this is the spanning from the right to the left fibrous trigone, from the right to the left fibrous trigone, with that area of aortomitral fibrous continuity. So that non-coronary sinus is completely supported by fibrous tissue. We're starting to get into the membranous septum there, which I've colored blue. And here is getting into the left coronary sinus, which initially is supported by that fibrous tissue. The more anterior we go, however, we start to get into the left ventricular free wall. And you can see how that muscle is incorporated into the base of the more anterior aspect of the left coronary sinus. And then as we go anteriorly along the left coronary sinus and the entirety of the right, you see the myocardium from the interventricular septum incorporated into the bases of those two sinuses. So you can see that muscle incorporated into the base of those two sinuses, again, the entirety of the right and a portion of the left. Now we're going to rotate. So we're looking from inferiorly from the apices of both verticals up at the left ventricular outflow tract at the aortic root. There's the membranous septum between the non and the right coronary sinus. This is now positioned anteriorly. There's the left coronary sinus. There's the aortic leaflet of the mitral valve and the aortic mitral fibrous curtain here. So we'll dissect further up into the aortic mitral fibrous curtain. You can see the interventricular septum and the free wall of the left ventricle as we come further up. So again, the interventricular septum supporting the entirety of the right and a portion of the left supported by that and the LV free wall, and then the aortic mitral fibrous curtain, the infraseptal recess, right fibrous trigone, and the membranous septum supporting the entirety of the non and a portion of the left. And as we cut up, you can see how this muscle here is incorporated again into the base of the non and a portion of the left coronary sinuses. And then we'll flip it over and we'll look from superiorly down at the aortic valve. So now a more intuitive view that we're used to with the atrial septum. So this is posterior, this is the non, this is the left, this is the right. So this is a surgeon's view. And you can see that myocardium incorporated into the entirety of the right. And we'll see a little more difficult to see, but a portion of the left. So as we come, so the entirety of the right, and then this myocardium ends right in this location here. So a portion of the left. The rest is completely supported by fibrous tissue with no myocardium incorporated into their bases. So the ventricular, the anatomical ventricular arterial junction is not annular. It is an incomplete line that spans across within the sinuses of the right and a portion of the left. That's coming down to the virtual basal ring plane.
So now you appreciate the overall arrangement of the aortic root, and as clinicians, you will want to assess the dimensions of the root. This is particularly important in the setting of Marfan syndrome. It's important in the bicuspid valve. So how do you assess the dimensions of the root? And this is important because we need to emphasize now that what you as echocardiographers call the annulus is in fact what we call the virtual basal ring, because it is a geometric construction. You make the so-called echocardiographic annulus by joining together the nadirs of attachment of the semilunar hinges of the valvar leaflets. But you also measure the root at other places, and you need to take note of the sinutubular junction. You need to take note of the mid-sinusal level of the root. And more importantly, if you are contemplating repair of the aortic root in the setting of an abnormal arrangement, you need to take note of the location of the leaflets within the root. And one of the beauties now of computed tomographic analysis or magnetic resonance imaging is that you can see precisely the arrangement of the root, and you can now put into play all that we have been discussing today about its anatomy. So this is another of the images prepared by Shumpei-Murray. This now is a planar image, and you can see the level of the sinutubular junction. Again, you can see how the virtual basal ring is made by joining together the nadirs of attachment of the valvar leaflets themselves. And you will note now the virtual basal ring, the diameter of the virtual basal ring is much less than the diameter of the sinutubular junction. But the widest part of the root is, of course, the mid-sinusal diameter. And you will know that you have to measure all these things. But look how now you also see the location of the leaflets within the root. And as they come together, their area of apposition is in the lower part of the root. And if you want to, you can measure the geometric height of the leaflets, and you can also measure what is known as their effective height, which is their area of coaptation. And now to complete our look at what's going on in the moving situation, Justin is going to finalize our consideration of the arterial roots by showing you how you can assess all of these features using virtual dissection.
So a pretty dense topic that could be its own lecture in and of itself. So we'll scratch the surface and hit the high points, but I would recommend to anyone interested that you read this recent review where we go over the normal and congenitally malformed aortic root anatomy and discuss how can you assess this with accuracy clinically and apply this to guiding surgical repair. So the first concept I want to discuss briefly is measuring the aortic root dimensions and that of the virtual basal ring plane or echocardiographic annulus. So the cross-sectional imager can use one of three different methods shown here from A, D, and G. The first, panel A, is often referred to as the cusp to commissure measurement, or I would describe it as a center of sinus to opposite commissure measurement. There are normal adult values for that. Panel D and G, however, have both been ambiguously given the name cusp to cusp. And while my institution often uses measurement D, there's no normative values for that in adults or in pediatrics. However, this has been demonstrated to more accurately correlate with two-dimensional long axis imaging, how we measure by echocardiography. So I often will use this and relate it to the PHN Echo Z scores. Panel G, also often referred to as cusp to cusp, is measuring from a largest diameter between the sinuses. And you can imagine without a fixed endpoint, even though this hasn't been looked at, it's probably not as reproducible as this center of sinus to center of sinus measurement. Importantly, if we look in these corresponding long axis panels, you can see that when you hover from the yellow to green line, you can have a difference of anywhere from 4 to 6 millimeters, so very significant. And that's how we're hovering in echocardiography. Also, if we relate it to this last column, which is the virtual basal ring plane, you can see how we're cutting that oval shape echocardiographic annulus in a very oblique, almost nonsensical plane. And unless you hover and really open up that plane where you get somewhat analogous to a minor axis of that oval shape, you can see how you can get highly variable values when we're hovering in that plane. So next, I want to briefly touch on the different metrics used to guide surgical repair, especially that of the incompetent valve to try to restore valvar competency. So these are the effective height, which is a measurement from the virtual basal ring plane up to the central zone of coaptation. The geometric height, which is a measurement from the nadir or center of the sinus up along the midline of the leaflet to the central tip near its central zone of coaptation. So that is the geometric height. The coaptation length is a measurement in that central zone of coaptation. And for adults, on average, that's about 4 millimeters. The effective height for adults on average is about 8 to 9 millimeters. And then the coaptation height is a measurement from the virtual basal ring plane along the long axis of the interleaflet triangle up to its apex at the sinotubular junction. And lastly, the free margin length is just that. It's a measurement along the free margin of the leaflet. So these metrics can only accurately be measured using three-dimensional imaging with multiplane reformatting, whether that's by three-dimensional echocardiography, magnetic resonance angiography, or computed tomography. And you can only, using multiplane reformatting, it allows you to get into this center bisecting plane where you're cutting from a nadir of one leaflet and sinus across its center line, and then across the opposite zone of apposition and commissure. And that'll give you this view here where you have this double shadow of that zone of apposition, and then opening up one of the sinuses down to its nadir. And using multiplane reformatting, we can accurately understand where the virtual basal ring plane is, and then we can measure these various metrics. When you're hovering in a two-dimensional echo plane analogous to lines A and B, you have no idea where the virtual basal ring plane is. Also, as we go laterally along the zone of apposition, there's a normal, natural increase in the three-dimensional surface area of coaptation. So you can get falsely elevated measurements of coaptation, and you can significantly over and underestimate these various metrics. And you can imagine if these metrics are only a few millimeters, errors of just a few millimeters can be highly significant. So for those who are more interested, I would direct you to these various papers.
So there you have it. We have discussed the valves of the heart to complete our assessment of normal cardiac anatomy. What we have shown you is that the atrioventricular valves guard the atrioventricular junctions. The arterial valves guard the ventricular arterial junctions. And what I hope we've also emphasized is that properly to understand their anatomy, we need to consider them in terms of valvar complexes.
Very nice presentation. Thank you, all of you. Really, it was a very, very good presentation. Where's my camera? Okay, cannot to start the camera. Anyway, and
You're stopping.
I'd like to. I don't know why.
Videos at the moment, Sasha.
Yeah, Sasha. Sasha, get us back.
Coming.
Get us back.
Yes. Here we go. Perfect.
Mine is not possible yet, but anyway. And I think Norman cannot turn on his camera as well. Start my video.
I can't get my video working. It's
Okay.
you stopped it and I can't get it working.
Sasha doesn't want anyone to see us today. Norman.
You know,
Sure. So I'll just let you look at my name and talk. I think this is a wonderful session. It certainly gives one food for thought as a two-dimensional person, that one has to be very careful in making assumptions. And Justin showed this so beautifully that when we look at the virtual basal ring, we're going through the nadir of the sinus in one and right through the junction between the two sinuses in the other dimension. And to further complicate this, when we use a ring to develop a Doppler assessment of cardiac output, we're actually not dealing with a circular left ventricular outflow tract. The left ventricular outflow tract is also not circular. So perhaps that's why echocardiography has not been absolutely spot on in making calculations, because it doesn't assume dynamic three-dimensional dimensions in making this calculation. And not only are we looking at a non-moving heart, but when the heart moves, all of these aspects of the left ventricular outflow tract change their dynamics. And so in systole, as the blood is ejected into the aorta and the forces press on the surfaces of the ventricular walls, the aortic walls, the aorta changes its dimension throughout the cardiac cycle. So I think that the session was really quite sobering today as an echocardiographer to look at this and see all of the weaknesses that we have to consider when we make the measurements of cardiac output and aortic root dimensions. I think this was masterly session. The way that the morphology, the embryology, and the virtual dissections of Justin were put together will really leave nothing to be desired in terms of a perfect articulation of these complexes. That's all I have to say.
Norman, we can
Now I can see you. Very good.
Morning.
Adrian, do you have anything to show us today?
Oh no, I don't have anything to show that belongs to me. And I think that Justin showed very beautifully, and Diane showed very beautifully in their dissections what we're looking at when we look at this on echo.
Norman, to me, you've encapsulated the whole thing with your comments, and I think you've put it into context. I really think you've set the whole thing where we wanted it to go. You've emphasized the problems that exist. How do you think we can, is there any way we can get around the problems?
I think, Bob, one of the strengths of today's session, and in fact in all of the sessions, is the application of morphology to what one looks at in an echocardiogram or a CT scan or an MRI. And one has to understand the morphology in detail in order to understand what you're looking at, and then one doesn't make mistakes. So I think that you've all of you today have done that so beautifully. I mean, the fibrous skeleton of the under part of the root was so beautifully defined by Diane today. And I think that we have to realize what we're looking at when we look at an echocardiogram. And that's really, I think, the sobering point for me as an echocardiographer to look at this is that, there is more in terms of the anatomy than you can see with an echocardiogram and with a single plane of anatomy. And we still have some weaknesses because of the dynamic nature of this examination, because the real time the aortic root will change its dimensions by with just a small amount of exercise or sympathetic stimulation can change its dimension by up to 17%. So, it really, even the fact that we've seen all of these dissections in the live situation, there are other things that we have to consider in terms of the timing when we make these measurements. So the whole answer is not yet in, but it's coming.
Grace, is Justin with us? I can't see him.
Yes, Justin is here.
Yes, I am. Yes. And I agree with Norman, and I would just emphasize two-dimensional echo is our mainstay of clinical evaluation, and that certainly we're not trying to diminish the value of that. It's exactly as Norman said, we need to understand the three-dimensional anatomy and how we're assessing it by two dimensions. And when we have patients that require more detail, then when possible, whether it's by three-dimensional echo or whether we need to consider things like MRI or CT where we can get three-dimensional data sets, then we need to do that. And I recently was trying to review our understanding as a community of how we assess aortic valvar area. And there was a paper, I forget offhand, Norman, maybe you're familiar with it. It was in the late 1990s that looked at pediatrics and assessing between two-dimensional echo and three-dimensional echo the area, and it was showing the discrepancies of that. And there's a number of papers looking at various anatomy, looking at the mitral valve and so on, of comparing MRI to echo and so on. But the general point is that the more we can do three-dimensional imaging, the more accurate we can assess these type of anatomical and functional features when that information is crucial to patient care. But I would just emphasize when we talked about, when the one point you made about, and that I made about the oval shape of the echocardiographic annulus, the images that I had shown when I was showing the measurements there of the aortic root and comparing it to the virtual basal ring plane, those were in diastole. And so that, like you said, it's a dynamic structure. And we know that that plane is much more oval shaped in diastole and does become more circular. Sometimes a lot when I measure MRI and CT, it is very circular, but often it still does have an oval shape to it. So So I think there is certainly some error to that measurement by two-dimensional echo, but sometimes maybe not as dramatic as what my images suggested in diastole.
Justin, a question's just come in from Omar Alganald, and perhaps you can answer this for us. And he says, how easy is it to disseminate such amazing virtual scans to assess the heart to a worldwide audience? Is it only getting a machine, or is some special training needed?
Certainly, there's a learning curve with any three-dimensional imaging, and Dr. Yu is much more of an expert than I am in three-dimensional imaging, and he holds a lot of courses that for both surgeons and for imagers, and so there's certainly any three-dimensional imaging, there's going to be a sharp learning curve, but I think he would agree the main emphasis is, and the exact point of these sessions is that as three-dimensional imagers, we can make our images look however we want. We can put an ASD in a patient that doesn't have an ASD. If that, like the CTs I've shown with the contrast timing, sometimes structures don't look how they look in real life because of how that contrast and the unopacified blood is interacting with the surrounding tissue. So the main thing is you have to know the anatomy. You have to understand the anatomy. You have to understand what you're looking at by your two-dimensional imaging. And so when you make those three-dimensional reconstructions from these multiplanar formatting where you're seeing the two-dimensional planes, you have to know the anatomy first. I think that's the key point. But to learn these different techniques, and if you wanted to specifically learn the technique that I do and that I have learned from Shunpei Mori, I've mentioned this before. We're going to have at the World Congress in Washington, D.C. in 2023. We're going to have a anatomy and 3D imaging lab. Dr. Yu will be there and many other three-dimensional imagers, and there'll be opportunities to learn these different things. There's Dr. Shijun has courses he does. So there's plenty of opportunities to learn along with reading some of our publications and so on. And I'd be happy to correspond with anyone who wants to learn as well.
The World Congress of Pediatric Cardiology is 18 months away. It's a long time.
Right. Well, it's hard to just teach it in a lecture, right? It takes time. You're going to spend hours I can show you things, and then you're going to spend hours yourself of learning.
Yeah.
We're fortunate that we have June with us again today. It's good that you're joining us for these sessions, June. Justin's commented on you are one of the masters of doing this sort of thing, but you've tended to go much more for 3D images rather than the virtual dissections. Do you do the same sort of thing that Justin has been doing with virtual dissection?
Yeah, absolutely. What Justin is showing, what is a very important part, is I call that endocardial surface imaging, which is that in the CT scan, you get rid of contrast medium. Actually, you make the cavity like an air. So you're looking at the surgeon's view inside the heart beautifully. And then also that one video clip shows the cine imaging of the inside of the heart. That is we really describe that dynamic anatomy, which is crucially important in better understanding of anatomy, no question about it. And then Justin, I haven't seen that any people having better demonstration of the anatomy in living individual than you do here. So I have here, if time allows, I have one comment and one question. Do you have time or?
Oh, sure, carry on.
Yeah. So my comment is that we need to emphasize to imagers, fibrous continuity is not actually the absence of distance. So what it means is that we talk about the hinge point of aortic valve and mitral valve. That is a major part is that covered by aortomitral, the curtain, and also at the edge by the the leaflet triangles. So what it means is that in echocardiography, the distance between hinge point of the aortic valve and mitral valve is natural. That should not be regarded as the sign for having short infundibulum, because infundibulum, we described that the absence of muscle, right, at least in one part. And that does not mean that in echocardiography there is no distance. So that is a little bit confusion the images may have.
Joan, if I can comment on that, you make an excellent point, because what I showed in the beginning of my presentation today is we start off with a muscular infundibulum in the left ventricle, and then it becomes fibrous. And you are absolutely right to emphasize that there is then still space between the hinge, even the nadir of the hinge of the aortic valve and the mitral valve. There is still space between the two hinges. It's a very good point you make.
As a same token, we define the perimembranous VSD as the defect having aortic mitral tricuspid valve in fibrous continuity. That also is that mitral valve actually physically by distance is off from the defect, because it is the septophobic position. So that also should be emphasized to imagers. So perimembranous VSD, unless that it is deeply inlet extended, and then tricuspid and mitral valve, there is no opposite attachment. Otherwise, still, anterior leaflet mitral valve hinge point is away from the ventricular septal defect. So that is from the imaging standpoint of view, we should emphasize.
Indeed.
Yeah.
So I've noticed, for example, when there is a subaortic membrane, that there's often a space, June, between the mitral valve and the hinge point of the aorta. Are you just saying that that's a normal phenomenon and we should accept it? Or does that mean that there is actually some infundibulum, in quotation marks?
So that if that continuity is filled by muscle, that is infundibulum. If there is no muscle piece there, there is no infundibulum. That is what I understand.
Correct.
Yeah.
Good.
So the question is then, thinking about here the subpulmonary muscular freestanding sleeve. So when you have a doubly committed juxtatorial VSD, we define that isolated VSD, but actually the pathology is more than that, because now that here you don't have a freestanding, the infundibulum in that particular situation, because pulmonary valve and aortic valve are in direct fibrous continuity with the fibrous raphe, and then freestanding infundibulum at least partly disappeared, right? So that's what I'm saying, that doubly committed juxtatorial VSD is more than simple VSD, but that finding is not crucially important clinically, but that is not really simple hole in the ventricular septum.
Well, we've emphasized that point for a long time, June, because the defect, in fact, is comparable to the situation in common arterial trunk. And the difference is you can make comparison with a common arterial trunk, but with divided orifices, divided rings for the aortic and pulmonary valves.
So with that, the common understanding agreement, what is the little bit strange is that when you talk about doubly committed VSD in the presence of double aortic right ventricle with a bilateral infundibulum, it is completely different story about doubly committed. So that is a little bit of leading some confusion among people about doubly committed in the context of otherwise normal looking heart versus that doubly committed in the presence of DORV, especially with the bilateral infundibulum.
Well, we've clarified all that, June, when we pointed out that in double outlet right ventricle, it's an interventricular communication. It's not a VSD.
Today's on the valves.
But I think Shijun is getting to the point that in double outlet right ventricle, the interventricular communication, or VSD, is the focus clinically is often on the hemodynamics, whether it's committed to the aortic root, pulmonary root, or doubly committed. And when clinicians use doubly committed, they're they're not recognizing that that's different than the real phenotype of a doubly committed VSD. And it also emphasizes the importance of this session of understanding the development of that in the doubly committed VSD. It's related to the male development of the proximal outflow cushion that leads to no infundibulum being formed under the pulmonary root.
Or it can be. I mean, it's the whole point that the doubly committed is making the point that the shunt is to both arterial trunks, but whether it's juxta-arterial or whether there is an infundibulum present is yet another variant. All of these have to be taken into account. But that's getting us away a little bit from the aortic root. There are other questions that I can't answer that you can all look at the questions and answers, Grace. I can't answer these. There's a question from Mateo Rios Valdez. Norman, can you answer that?
Yeah, let me read it first.
He's asking, when you have a hypoplastic valve without significant leaflet stenosis, is there a critical site of stenosis, for example, ventricular arterial connection, or it is all complex of the valve that produces stenosis?
I think that it's not just a simple thing. It's a complex thing, as you said. Not just a simple valve that's hyperplastic.
But I guess it can be all complex. All parts of the complex can be involved. You would have to assess each component of the complex separately, individually, would you not?
Correct.
Justin, would you like to comment on that?
Yeah, I agree. If you think about, let's say, a bicuspid valve, a functionally bicuspid valve that the aortic valvar opening area is stenotic, you're going to see on echo the increased flow or alising on color Doppler at the leaflet tips getting up towards the sinotubular junction, since that's the area that is the issue. Even if you have a normal echocardiographic annulus, normal aortic root dimensions in sinotubular junction, as opposed to what he's describing, which is where you might have hypoplasia involving the entirety of the aortic root, or potentially just the echocardiographic annulus plane, even if in the valves may open fine, then you may have stenosis starting at the level of the echocardiographic annulus. And in that situation, if that patient had to go to surgery, you wouldn't just have to address potentially the valvar leaflets, but instead focus on the aortic root complex.
Grace, if I can continue this, there's another question from Dennis Wood. You want to?
I'll take that one, Bob.
Okay. This is for Norman.
Hello.
A long time.
Dennis, thanks for that question. I mean, we're talking about something in 1973 when looking at premature infants.
Norman,
there were no normal
just
standards.
1 second. Let me read the question so everybody can follow up.
Sure.
Our audience. So Dennis asked, a long time measurement in newborns has been the aortic to left atrium ratio for PDA. Could you discuss the errors possible for this measurement?
Well, yes. Obviously, the errors are if you don't get an accurate measurement of the left atrium. The problem was in 1973, there were no normal standards. And so in order to get a standard, we took something that was quite reasonable, and that was an aortic dimension on M-mode echocardiography, where we saw the parallel root and we saw the atrium behind. So obviously, if you don't get the aortic root, you can make an error. And if you look at the left atrium, the posterior root of the aorta to the posterior wall of the atrium is variable because there are pulmonary veins coming into that area. So that created a problem in terms of making a measurement, that you had to get an area of what was really left atrium. And basically what we were measuring was left atrial dimensions. Now, the normal left atrium is only about 2/3 of the size of the aortic root. And what happens when you have a left to right shunt at ductal level, as you would get in a premature with a large patent ductus, the left atrial size increases. And the only way we were able to assess this was by comparison with the aortic root. And on M mode, of course, there are many difficult ways of getting it, but I think it's a fairly reasonable measurement when you get the aortic root with the valve tissue in it, that you get a reasonable size. It's not perfect, but it's a reasonable size. And what we discovered in the early days of doing this is that when the left atrial size was greater than 1.3 times the size of the aorta, that this was a significant hemodynamic effect. And obviously there are a huge number of problems that can occur. For example, is there an atrial shunt, which there almost invariably is in small babies, that complicate the making of this measurement. But I think it's still a good sign that when the left atrium is enlarged, and how we assess left atrial enlargement today is a completely different issue. We can look at normal data for left atrial size in variable ways, including three-dimensional assessment of left atrial size. So I think that's more or less a simple answer to your question, Dennis. It's a very difficult question to take care of in a short amount of time, but I think that's a good approach to this problem.
Thank you, Norman. We have one last question from Omer. He is asking, what is the importance of what called commissural competence or alignment of both semilunar valves?
Who is answering that? Justin.
Yes, so I'm not quite clear what the question is. It sounds like we're talking about comparing both pulmonary root and aortic root, and what comes to mind is in transposition. So I'll get to that. But if we're speaking just with the aortic root, then where the commissural alignment becomes important, Hans Håkon Schaefer, the adult cardiothoracic surgeon in Germany, has demonstrated and published in functionally bicuspid valves, when you look at the two commissures and how they're positioned to each other, whether they're straight across from each other at 180 degrees, which you would call symmetrical alignment, or whether they become closer at 120 degrees and start to look more like how a normal trileaflet valve may look, where he would call it very asymmetric. That he's shown that helps to determine what the better repair strategy would be, whether tricuspidization or bicuspidization of the valve. And there's a lot of published literature on that you could refer to from Dr. Schaefer's. But I'll let maybe Adrian could weigh in talking about from the surgeon's perspective, if Omar is discussing about transposition with commissural alignment or male alignment, or if there's some concept I'm not understanding that they're referring to.
Is Adrian with us, Grace?
Yes, he is.
I'm here. Thank you very much, Justin and Diane, for wonderful images. And Prof, I'd like to I'll mention about the commissural misalignment, but I'd like to point out to something that we've seen on the last slide of embryology, when it is described of subaortic infundibulum, and yellow area that we used in the past for atrioventricular canal myocardium. So I need you to clarify that, because it looks like the subaortic infundibulum is made of atrioventricular canal myocardium. In that regard, if you can answer now, then I'll continue my question.
I think it's part of it. The other part of it, of course, is the ventricular infundibular fold. I put that was the only part that was available for me to be colored. And you are correct that becomes effectively the vestibule. And then it is the inner heart curve, essentially, which becomes remodeled, as June has been emphasizing, to form that fibrous tissue. So I use but you are correct. I use the atrioventricular canal myocardium as a marker.
Okay, that's important, because this is a question for Justin or June. how reliable are we when we think that we describe the tissue as being fibrous versus muscular on the CT? Because we know there is a normal variation between the fibrous and the muscular support. And in that regard, what Shi-Jun rightly raised is the term of curtain. We use the mitro-aortic curtain term. This curtain is not part of the aorta, is not part of the mitral. It's a structure on its own. Isn't it, Prof?
Correct.
So that's where the infundibulum becomes even clearer that there is a distance there because there is a curtain.
So there is the actually pitfalls in imaging. If the muscle is very thin, I do not think a CT or even echocardiography will tell whether there is no muscle or not. So in that regard, that is why I emphasize to the people that simply looking at some distance between the hinge points does not necessarily mean that semilunar valve is supported by muscular infundibulum. But clinically, it's not really very clinically important.
True. True.
As a surgeons, we always measure in theater, in OR, using the Hager dilators. So whatever diameters we get preoperatively, we always check them with the dilators that we use in theater to find the shortest, the smallest one.
But Adrian, you wouldn't necessarily, you're pushing that is the diameter of the outflow tract, isn't it? You're not, the point June is making, you would not be able to see whether the posterior wall had a little bit of myocardium within it by passing your Hagar up into the aortic root.
Exactly. It's just a number that we get. But I think that will be important in terms of studying the extent of the fibrous versus myocardial support when we'll discuss the various pathologies to see what happens in that situation.
Grace, can I make another comment?
Yes, sure.
Because there was one question that you've taken away, which was from a man who was asking, he was a pediatric cardiologist. It was there a moment ago, it's gone now. And
I know, Justin just typed privately for him. He answered privately for him. Don't worry, it was answered. He was asking about the possibility of a course or a training on MRI and a CT scan, and Justin just answered him that currently there's nothing in mind, but maybe we can do something with
I told him I would discuss with Grace potentially. Since there's a lot of interest, I told him that I would discuss with Grace. Since certainly this session, the focus is on the anatomy and not so much how to do the 3D reconstruction. So maybe that's something separately we can look into. And as I mentioned to him, once I'm established at the Cleveland Clinic, anyone's welcome to reach out to me for personal communication. I can help them if they're interested.
That was the point I was going to make, Justin, because I know and you know that this is your last day in Cincinnati, and we're very grateful to you for joining us because we know how busy you are as you make this transition. So I don't think you'll mind me telling everybody that when you join us next time, you will be broadcasting to us from the Cleveland Clinic. You have an important position that you're going to take there, where you're going to emphasize, I think, the key role of unifying all these things. June is a radiologist. You are a pediatric cardiologist. You do all these things together. The question was about how we can unify these specialties. I mean, would you like to tell the audience who are still with us what you hope to achieve when you get to Cleveland?
Yeah, and I would say I don't think it's anything different than Dr. Yu is already doing in Toronto, but the goal of this is obviously it's good as an educational tool, but the goal is to try to personalize patient care. And that again goes to the importance of these sessions is whether you're an imager, a surgeon, or a clinical cardiologist or pathologist, you have to understand the anatomy. If you don't, like anything, if you don't know what to expect or to think about, you're going to miss it or misinterpret it. So you have to understand the development, the anatomy, and the goal for me as an imager and Dr. Yu is to try to apply this very personalized understanding to patient personalized procedural and surgical planning. So that at the Cleveland Clinic, I'll be the co-director with Hani Najm for a congenital valvar surgical planning center to try to apply some of this information to personalize surgical planning and procedural planning.
Well, thank you for that. And we know that you're about to embark on a Disney cruise with your children. So we hope you enjoy that. And we thank you for all you've done for us whilst you've been in Cincinnati. We look for equally great things when you arrive in Cleveland.
Thank you.
Guys, amazing session once more. And what Dr. Anderson said is true. These sessions are being better and better with the input of all of you. Diane is making beautiful images, and now Justin is bringing amazing information, and we all are learning more and more. And this is very interesting if you see how this, we already talked about all of these topics 2 years ago, and now we are redoing it in a better way, with a different approach. And this is really amazing. Guys, thank you very much. See you in 2 weeks. And good luck for you, Justin, in your new job. I wish you all the best. And thank you for everybody that joined us today. See you soon, guys.